Good morning, Chairman Pitts and other distinguished members of the committee. Thank you for the opportunity to testify about the Office of Inspector General's work associated with the federal medical assistance percentage matching rates. My statement describes two vulnerabilities associated with the federal-state partnership that governs the financing of the Medicaid program. First, in certain areas of enhanced matching rates, OIG has seen states claim federal reimbursement for expenditures that do not qualify. Second, in some instances, we have seen states use financing mechanisms to shift costs to the federal government. I will briefly discuss each of these issues. Most Medicaid expenditures are eligible for federal reimbursement at the regular matching rate. The regular FMAP rate varies by state and, as said earlier today, cannot be lower than 50% or higher than 83%. There are numerous exceptions, however, that allow for the use of enhanced rates. For example, family planning services are reimbursed at a 90% FMAP rate. Enhanced FMAP rates provide states with additional federal funding for specified populations and services, but they also create vulnerabilities that expenditures could be claimed incorrectly. The OIG has conducted audits to determine if expenditures were included in the correct enhanced rate categories. In general, we have found instances where states incorrectly claimed expenditures in one of the enhanced rate categories instead of properly claiming the expenditures at the lower regular FMAP rate. As an example, we have found many cases where states used the 90% enhanced family planning rate for services that were Medicaid eligible but did not qualify as family planning. In total, we identified more than $82 million that states received inappropriately. In addition to vulnerabilities that exist with enhanced FMAP categories, the shared nature of Medicaid financing provides opportunities for states to shift cost and distort the federal-state cost-sharing partnership. While mechanisms such as provider taxes, intergovernmental transfers, and inflated payment rates increase state funds, they distort statutorily determined FMAP rates and undermine the federal-state partnership in financing the Medicaid program. In a 2014 review of healthcare provider taxes, we found that a gross receipts tax on Medicaid managed care organizations in one state appeared to be an impermissible healthcare-related tax under federal requirements. Using this tax, the state obtained nearly $1 billion in federal Medicaid funds from 2009 to 2012. CMS issued guidance to states in July 2014 to clarify its policy. We are currently performing work to determine if states are in compliance with this guidance. State policies that inflate federal costs for Medicaid are not new. In a series of reports from 2000 to 2005, we found numerous examples in which states used intergovernmental transfers to increase the amount of Medicaid expenditures the federal government would pay. In some cases, states transferred the additional federal money to their general treasury to be used for other purposes. Both Congress and CMS took action to close this loophole. While the changes dramatically improved the situation, they did not entirely eliminate the problem. Collectively, the findings of our work over a number of years suggest that improvements are still needed to safeguard federal Medicaid funds, including a definitive regulation linking payments for public providers to the actual cost of providing a service. In conclusion, the federal and state governments share responsibility for operating the Medicaid program and for the integrity of the dollars invested. Given projected growth in Medicaid, it is critical that CMS and states focus on strengthening program integrity. OIG is committed to providing effective oversight to help ensure that any inappropriate payments are detected and that eligible beneficiaries receive the needed and appropriate health care services. I would be happy to answer your questions.